Welcome to the CGA-IGC Journal Club podcast series. This is brought to you by the Education Committee. Each episode will highlight a recently published journal article that is important to the field of GI cancer genetics and feature an interview with one of the article's authors. Keep listening to find out more about this episode's host, guest, and featured article. My name is Maureen May. I'm a genetic counselor and member of the CGA-IGC Education Committee, and I will be your host for our podcast today. During today's podcast, I will be speaking with Dr. Bronwyn Bedrick, a resident physician with the Johns Hopkins Gynecology and Obstetrics Residency Program. Dr. Bedrick and her colleagues recently published an article in the November 2021 issue of Obstetrics and Gynecology entitled Creating Breast and Gynecologic Cancer Guidelines for Transgender Patients with BRCA Mutations. Thank you so much for joining us, Dr. Bedrick.
Thank you for having me.
Let's get right into it. Tell us a little bit more about where the idea for the article came from and what your team had hoped to accomplish with it.
Yeah, like a lot of good ideas. The idea for this paper was actually inspired by a patient. We had a woman come into our gynecologic oncology clinic for a risk-reducing salpingo-oophorectomy. She had just been diagnosed with BRCA after a breast cancer diagnosis. And most patients who have children and a new diagnosis of an inherited cancer mutation will ask what it means for their children. And this patient specifically asked us what it meant for her child who was transgender. We didn't really know how to counsel her right away. And after reading through the available, albeit scant, literature, we realized this was an important gap for the population that is already marginalized from healthcare. The main goal for this paper really was to try to synthesize the available information for other providers who might be facing similar clinical situations. We also wanted to continue to push the conversation about the needs for transgender patients in medicine. There are an estimated 1 to 1.5 million Americans who identify as transgender, and this is about the same number of individuals that have type 1 diabetes, and yet so little of our education and training focuses on caring for this population. There's also a group that is still very much marginalized from healthcare. About 20% of transgender patients have been denied care due to their gender, and 25% of them have also had to teach their provider about transgender people in order to receive care. And an additional 25% report not seeking medical care that they need for fear of mistreatment. And while there's a growing interest in providing comprehensive and compassionate care to the transgender community, the majority of research still really focuses on infectious diseases and mental health. We really want people to start asking and ultimately figuring out the answers to how to care for transgender patients with different health conditions.
Wow, thank you. That's a really interesting background story. And I really appreciate you framing this as, in some ways, a proactive health issue. This is just a really great article. And I want to congratulate you and your co-authors on publishing it. So one of the things that you mentioned just now about your patient is that there were some concerns for family planning and for family issues because these are hereditary conditions. And so in your article, you do acknowledge the need to consider family planning in any decision-making about risk-reducing interventions for any patient with a hereditary cancer predisposition. What should those discussions additionally include for transgender individuals with an inherited breast or GYN cancer risk syndrome?
Every patient that's planning pregnancy, regardless of their gender identity and whether or not they have an inherited breast or GYN cancer syndrome, really should be counseled about the variety of different genetic screening and testing options that are available. Obviously, patients who have a known mutation who are at risk of having a known mutation, say if they have an immediate family member with a mutation, should have a more in-depth discussion about the availability of certain technologies to reduce the risk of their offspring being a carrier for that mutation. But the detail at which to discuss certain options really needs to be tailored to the patient or the couple's reproductive goals. For transgender patients specifically, the option for fertility preservation should be discussed prior to starting estrogen or testosterone therapy, even for adolescents, which may be challenging for adolescents who may not have thought really about their fertility in general. But gametes can be preserved for years prior to making any decision about reproductive goals. And so some of those decisions don't necessarily have to be made at that time. Ultimately, anything that's available to cisgender patients is also available for transgender patients with respect to fertility preservation or IVF. And so really any discussion that you'd be having with a cisgender patient, you can also have with a transgender patient.
So you touched on age there in particular, and the fact that we're understanding now that the earlier we can provide gender affirming care for transgender patients, the better the outcomes seem to be. So these may be teenagers that we're talking about.
Mm-hmm.
So that's considerably younger than the age at which we typically assess people for hereditary cancer predispositions. What are your thoughts on balancing caution in testing minors with the recognized benefits of early gender affirming care?
Yeah, it's a very hard question, and probably one of the hardest questions, and one that I think a lot of people struggle with. I do agree with the recommendations to consider testing in childhood if there is a clinical indication, and I do think transitioning is a clinical indication. However, this has to be done on an individual basis, taking into consideration the maturity of the child and their stage of transitioning. People may be really concerned about the young age. We're talking 6, 7, 8, at which children start knowing their identity and want to transition and wonder whether or not we really should be testing children who are that young. And I agree that it's a hard question and a valid concern. And again, something I think really needs to be done on an individual basis. But at the very least, treatment in terms of transitioning should not be delayed for screening.
Well, lots of difficult questions and needs to balance there. I'm guessing that there is a multidisciplinary approach to this type of care in your center.
Yes, definitely.
One thing that you talked about that comes up a lot in the cancer genetics community is the timing of gender affirming hormone therapy and any potential impact that might have on cancer risks. What would you say is the state of our knowledge on cancer risk, either reduction or increases based on hormone therapy in the transgender community? And what more needs to be done?
Yeah, that's a great question, and that's a hard question. Unfortunately, a lot of the data that we have on the effects of hormone therapy on specifically breast cancer mostly, cancer risks comes from postmenopausal cisgender women. Transgender women may start estrogen at much earlier ages, and they may be on hormone therapy for longer periods of time than at higher doses than these postmenopausal cisgender women. And so even though we try to extrapolate some of that risk, it isn't necessarily the best comparison. Example, we know that breast tissue for cisgender males and females differ, and that molecular pathogenesis of breast cancer differs between sexes. For instance, cancers positive for human epidermal growth factor 2 or receptor 2 or HER2 are fairly rare in males, whereas more common in females, and a higher percentage of male breast cancers are estrogen receptor positive compared to female breast cancers. And so somewhat of it is more theoretical things that we know. To date, there really is insufficient evidence to conclude whether gender-affirming hormone therapy alters breast cancer risk. The evidence that we do have is limited predominantly to case reports and small cohort studies. And unfortunately, a lot of these studies don't publish information about hormone duration or dosing, or even if people are on hormones whatsoever. The largest study that we do have, which included over 3,000 transgender individuals, did find that transgender women's risk of breast cancer was higher than that of cisgender men, but not as high as that of cisgender women. And their cancer actually developed in a relatively short interval, usually less than 20 years from initiating hormone therapy. And then conversely, transgender men's risk of breast cancer was lower than that for cisgender women, but it didn't reach the level of cisgender men. So really what I'm saying is we just really need much better quality data in order to inform our information about risks.
I agree. And I think your answer is really helpful because it helps those of us who are seeing these patients and who are not experts in hormone therapy and who are not gynecologists and obstetricians. It helps us to understand what the specific limitations are and what's needed so that we can have these conversations honestly with our patients and help them to understand what we do know, what we don't know, and where we're extrapolating or guessing a little bit. So thank you. That's a very helpful framework for us. While we're thinking and talking about hormones, something I found very interesting in your article is that you talked about vaginal atrophy after testosterone treatment, and you connected that back to this idea that the majority of transgender men do not undergo hysterectomy. So since hysterectomy can be more difficult after testosterone and after vaginal atrophy, how do you think that conversation needs to be approached with individuals who are considering testosterone, but maybe at risk for endometrial or even ovarian cancer?
Yeah, I think it's a challenging question. And ultimately, the beginning of making the decisions about what treatment a patient wants and what kind of aligns with their gender identity, having discussions about all of these, what is known and what's not known. Ultimately, I think that's the most important thing in guiding when patients want to have their treatment. Sometimes they may decide early on that they absolutely know that they want to undergo surgery and to have hormones. And some men decide that they don't, that having their uterus remain in their body is something that is okay with them. It's something that's congruent with their gender identity. And ultimately, we don't really have enough information.
Yeah, it sounds like a key theme that keeps coming up in this conversation is that we don't know, but we can have the discussions, right? It sounds like you're in favor of really sharing this information with patients and doing some shared decision-making around these issues.
Mm-hmm.
So do you think that gynecologists should be talking with transgender men about possible reduced risks of endometrial cancer secondary to androgen use? Or do you think those data aren't robust enough yet?
With any patient, timing of prophylactic surgery for transgender men, whether or not it's before hormone replacement or not, for risk-reducing cancers, really it's a personal decision. Not all endometrial cancers express estrogen and progesterone receptors. And so not all cancers really we think that androgens would have any impact on. So, example for Lynch syndrome, we have no evidence to suggest that expression of estrogen lowers Lynch-mediated endometrial cancers. And so we wouldn't necessarily think that androgens would be protective for them.
So moving on to some of the other risk-reducing or prophylactic techniques that are used in patients who are at higher risk for various types of cancer. Think about surgical options. You make a distinction in your article between top surgery or chest surgery that's for gender-affirming purposes versus risk-reducing mastectomy, which is something that we're a little more familiar with in the cancer genetics community. And you talk about pursuing risk-reducing mastectomy prior to breast augmentation for trans women or masculinizing chest surgery for trans men. Can you talk to us a little bit more about the distinction between those surgery types and your recommendations?
Ultimately, the chests of cisgendered females and males are different in a variety of ways. And the purpose of chest surgery, whether it's for trans men or trans women, is to create an anatomic chest structure that aligns with the patient's identity. For trans men, this usually means removal of the majority, sometimes all of the breast. However, there's some times where breast tissue can remain in place in order to create kind of an aesthetically male chest. And so in a risk-reducing mastectomy, know that all the breast tissue is removed. And so our recommendation is that really for all of these patients who are undergoing any chest surgery is to remove any of that remaining breast tissue before doing augmentation, say for trans women, just to reduce needing to have things like mammograms and continual screening.
Going back to the question of prophylaxis versus reconstruction or gender-affirming chest surgery, what is the time frame patients should be thinking about for those? Is that a serial procedure where you need to have the prophylaxis done first with pathology to follow, and then a second surgery for the gender-affirming procedure? Or are these procedures that can be done concurrent?
I think that it ultimately can be done concurrently and avoids having to do multiple surgeries. We do know that there are some case reports of patients who had, say, their chest surgery and then were found to have breast cancer. But ultimately, that's fairly rare. And I think discussing those risks with the patient, especially based off of age and potentially other risk factors, say, when they've had any family members who've had breast cancer and at what age that they were at, just to kind of have an idea of what risk that patient may specifically have in framing that conversation. But ultimately, I think both of those procedures can be done concurrently with the knowledge that potentially other staging procedures would potentially have to be done if breast cancer was found in that tissue.
Okay, interesting. Thank you. We've been talking a lot about multidisciplinary care, and just now we were talking about surgeries that may need to be done with the input of lots of different departments simultaneously. What would you suggest for the provider who is listening from a more remote or less experienced center that maybe doesn't have that type of multidisciplinary support? Do you think that patients should be referred out for care? And if so, how can they find appropriate programs?
Having a multidisciplinary center, kind of as I've been alluding to, and these, what they're called transgender centers of excellence, can really take on a variety of needs for the patient population. And this includes a variety of different fields: plastic and reconstructive surgery, endocrinology, genetics, peds and adolescent mental health. And centers of excellence can provide care which reduce healthcare disparities and improve the overall health of the transgender community, and ultimately can provide world-class holistic evidence-based care and also can contribute to research. So these centers are very valuable, and if they are available to a patient, can really be life-altering. However, there are patients who aren't going to live close to those centers of excellence and still need care. There's a website associated with one of the professional associations for transgender health. It's called the World Professional Association of Transgender Health, or WPATH website. And this has a really great guideline and practice guidelines that providers can use to help guide their management in caring for patients who are transgender. And then there's also a list of providers on the website as well. And for example, a primary care doctor has a patient come in who is transgender and needs to see an endocrinologist. They can go onto this website and they can try to find somebody in their local community who has experience with treating patients who are transgender. And so not necessarily having to refer them out to a major multidisciplinary center, but able to at least provide their patients with care that is a little bit more streamlined for them.
That sounds like a fantastic resource. So a note for anyone listening to the podcast, we will make sure to confirm those links with Dr. Bedrick and get those posted in the episode notes. I think that's a fantastic resource for anybody who wants to learn more or to refer their patients on if needed. So what else is being done in this area of care, and how can we as providers and how can our patients get involved? Are there research studies that are ongoing? Are there registries that we should be encouraging sites or patients to sign up for that you know of?
It's a great question. I think ultimately the first step of any of this is creating safe spaces for transgender patients. Some of the criticisms that we received about this commentary was how many patients in the United States are transgender who have BRCA. And it's true, we don't really know how many patients there are out there, but a part of this is because of how unwelcoming the medical community has been for transgender patients historically and still is in many places. As a whole medical community, and also for the cancer genetics community, creating an environment where transgender patients are welcome will not only increase their ability to access care, but it'll also help us to understand how many patients are affected and what their risks are and how best to care for them. Another important step is also education for providers and patients, just like what we're doing here on this podcast. Then also just using the internet for really great resources like WPATH that I mentioned before. There's also great resources through UCSF as well. Ultimately, I really think what is needed is a good registry where we're able to collect patient information. Of course, there are a lot of cancer registries, and some of which do collect information on gender identity. But unfortunately, some of them don't necessarily differentiate between transgender men and transgender women, and they may not differentiate whether or not the individual has had any hormone therapy, have had any surgery. And this ultimately fails in helping us to understand how hormones and risk-reducing surgeries impact this population. And so really having some sort of registry that captures that information would be vital.
You brought up such an important reminder and point at the beginning of your response there. Before we can ask a patient to join a registry or to think about broader research questions, we really need to make sure that they feel safe seeking care for themselves. And that's something that I would encourage any of our listeners to explore the resources and the interviews and the webinars that we've tried to provide as a group here at CGA-IGC, but to also continue to seek out and share other resources with your colleagues, because that is such an important point that we have to make patients feel safe and encourage them to access care before we can think about the bigger research questions. So thank you for that. Thank you. Any final thoughts or things that you would like to leave our listeners with regarding this article or this area of transgender patient care?
One thing that I had wanted to mention when talking a little bit about what we can be doing for this patient population, when I was preparing for this podcast and looking through the WPATH website for providers, I noticed there was no genetic counselors listed. And there's also very little information listed in those guidelines about genetics. And so I think this is for anyone who's listening in the cancer genetic community who's interested in getting involved. I think this is a great place to start in trying to kind of start the conversation with transgender providers in trying to provide your expertise for this population.
That is so interesting. That is certainly a call to action for the cancer genetics community. And we love a call to action. We love a challenge. We love a project. So that's something that I would challenge all of our listeners to get involved in and get your colleagues involved in. Let's continue that conversation about how we can contribute to patient care. So thank you so much for your time today, Dr. Bedrick. This was fascinating. I know I learned a lot. I think that our listeners will learn a lot. And I look forward to this topic growing in depth and knowledge over time.
Oh, well, thank you very much for having me.